Now, we know you want to get to the open bar, but you know what would be even cooler than the open bar is talking with us about our awesome research while you're at the open bar. So what's our research on? It's called Developing Methods of Assessing Auditory Function for Minimally Verbal Individuals with Autism. I'm Weitekamp, and these are my partners, Nicole, Ouellette, and Olivia, Lutz. So let's get started. I think Kevin and Henry did a good job of kind of leading us into this with their presentation before, but show of hands, how many of you know someone with autism? It's a pretty prevalent problem, right? And it comes with a few communication deficits, a lot of which are due to hearing loss. Now, as it turns out, hearing loss is 10 times more prevalent in people with autism than it is in typically developing people. In addition to that, 25% of people with autism are minimally verbal. So that leads us to think, well, if we go and give them like an early form of intervention, as we'll call it, an early form of hearing diagnosis, and find out that yes, they do have hearing loss, we can earlier be able to give them earlier hearing treatment, and thus they can develop better communication skills and live an overall better quality of life. We've done the interviews on a few relatives of children with autism, and it does confirm that this early intervention process is necessary in developing the child's communication skills. Now you're all thinking, so let's just test their hearing. And that's an awesome idea, I love that idea. But there's a few problems that come with that as far as the differences between testing hearing in people who are typically developing and people with autism. Normally, the standard for testing hearing is called an audiogram. You go to the doctor's office and he says, raise your hand when you hear the beep. It's an active task. The problem is, with people with autism, they can't understand the task instructions, let alone output good results. So say, yeah, I can hear the beep. So we need to develop, or use rather, a form of physiological measurement to see how their hearing is, as this beautiful subject is doing right here. So that leads us to our objectives. What are we actually trying to do? There's two different ones. Spoiler alert, one of them worked, one of them didn't. I lost the coin toss, so I get to tell you about the one that didn't work. First of all, we're going to look at hearing thresholds via auditory brainstem responses, or ABR. And those are indirect measures of the cochlea from the brainstem. Second, we're going to be looking at the coding fidelity of suprathreshold sounds via the brainstem, which is an indirect measurement of the auditory nerve. So first, let's look at an ABR. What's an auditory brainstem response? It's a transient response to a transient stimulus, short in the time domain, but has a broadband frequency. Normally, the only way to elicit an ABR from previous studies is by giving this broadband frequency stimulus, which activates all areas of the cochlea here, which are divided into frequency sections. But how do we go and relate that to an audiogram, which only really gives us stimuli at specific frequencies? In this case, we would want to introduce specific tone bursts to our subject that target specific parts of specific regions on the cochlea. And we started doing this in 1 kilohertz and 4 kilohertz stimuli, and we did this for 16 subjects. What we're looking for in this ABR signal is a response called wave 5, and it's a direct response from the brainstem that generally tells us about cochlear function. So, as an intro, I guess, it's been shown from these previous studies that tone bursts generally haven't outputted these ABR signals. But, hey, look at that. That big peak right there is our wave 5. And we were fortunate enough to see this. However, this wave 5 was seen for the 4 kilohertz stimulus in 3 of our 16 subjects, and the 1 kilohertz stimulus, 1 of our 16. You're probably asking, well, what happened to the other 13/15 subjects? And unfortunately, due to a noise floor and possibly due to muscle twitches, a lot more of our data looked like that. And so you can see that there's a prevalent noise floor here. And that leads us to think, okay, so this study isn't what we would consider a success. However, it's still exciting that we are, as far as we know, one of the first experiments to elicit a wave 5 using tone bursts. So what can we do in the future to kind of improve upon this study? Well, we're going to do a few things. The first is increase the stimulus bandwidth. So instead of having it target specific frequencies, we're going to kind of broaden it out. So it still focuses on frequencies of interest, but it's a little bit more click-like. The second thing we're going to do is increase the sound level above 40 dBHL, which is the original level that we were presenting stimuli at. And finally, not shown on the slides, we're also going to increase the number of stimuli to get a better accuracy of the signal.
So I won the coin toss, and moving on to objective 2, we looked at auditory nerve fibers. Now, your auditory nerve fibers are crucial for encoding fine details of sound, like suprathreshold sounds, or loud sounds, like talking to people at a party. However, these are not picked up by an audiogram. And so, audiograms measure the lowest threshold that a listener can detect. So this is like going to an eye doctor and him asking, can you see something up here? And you're like, well, yeah. He's like, oh, your vision's probably fine. When actually, he should be asking, can you read the words up here? There's this level of detail that's not in an audiogram that we need to measure for auditory nerve fiber function. And so if these are damaged, we can't encode this level of detail, and this is called hidden hearing loss. And actually, 90% of your auditory nerve fibers can be damaged before they're picked up by an audiogram. So how do we measure this? We're going to use what's called a frequency following response, which is a sustained brainstem response. And again, we're using EEG, focusing on electrode CZ right above the brainstem. So this is a zoomed in version of our stimulus. The gray line is our carrier frequency. This is a high frequency to target a region of the cochlea. And the blue lines are envelope frequency at 163 hertz. And this is what the auditory nerve fiber is going to phase lock to. We had 4 different amplitude modulations, and so we're going to look at how the firing rate of the auditory nerve fiber changes with the amplitude modulation. And in hidden hearing loss, there's going to be a more significant change. So in our test, called the regular FFR, we use a 400 millisecond stimuli. We record 4,000 trials, but this lasts for 45 minutes. We cannot use this in a clinical test because you cannot ask an individual with autism to sit still for 45 minutes. It was hard enough to ask college students to sit still for 45 minutes. So what did we do? We created a rapid FFR where we had a 10-second stimulus. We recorded for 40 trials, and we only did it for 7 minutes. So we recorded 6 times faster. We recorded for 17 subjects. However, Nicole's going to get into this, but we only had clean data for 9 of our subjects where we could see direct correlations between methods. But I wanted to point out something interesting that we saw in some of our noisy data. So this is an example of a subject who could not sit still for 45 minutes. See this figure? It's just noise. There's nothing there. We can't diagnose any kind of auditory function at all. Whereas this other figure is our rapid method. There's a clear peak at 163 hertz, which is what we should see, because this is what the auditory nerve fiber is phase locking to. And so this is an example of when our rapid method would have actually been better than the regular method. So now Nicole's going to get into more details about the results.
So for the good results, we were primarily interested in learning about this one particular measure called the phase locking value, PLV. This is a measure of how well the auditory nerve fibers of a subject are phase locking onto that envelope frequency of our stimulus. So, for the regular method, this is an example just from one subject. Again, we can see the clear phase locking peak at the frequency of 163 hertz. Frequencies on the x-axis, and PLV is on the y-axis. But we're only interested in the first harmonic of this frequency, so I'm going to zoom in on that. And so we're trying to compare these phase locking values with, on the right is our new rapid FFR method. This is the 7-minute method. And again, we're comparing frequency with the phase locking value. An interesting thing to note here is that as the modulation depth decreases, the peak of the PLV also decreases. This is because as we decrease modulation depth, it becomes more difficult for the auditory nerve fibers to phase lock onto the envelope frequency. So this is a trend that we would normally expect. So that's great for one subject. But one subject does not a correlation make.